So what we're doing is we're taking this as a chance to kind of like talk about diseases that are common and reinforcing those concepts, and at the same time we have more time to kind of like speak about uncommon diseases, concepts that we didn't touch upon أو ذكرناها على عجالة. ف يعني this is therefore في ال case discussion series بتشوفون إن مو دائما الحالات متسلسلة، وبيكون في حالات صعبة alongside ويا حالات سهلة، وبيكون في أشياء جديدة ما تحكينا عنها. ف this is to kind of like يعني imitate a multi-headed microscope session. كنا احنا قاعدين كنا حوالين multi-headed microscope, and we're just getting cases. These are the cases that are coming on the day. All right, just to clarify that. المحاضرات كلها بتكون uploaded. But يعني I think they are being edited. الكلام اللي أنا أقوله في البداية هذا all of my meandering قاعد ينشال على أساس إن for the sake of time. Yeah, they're being edited for sound quality and all of that, and they're being put on the channel. There's about 4 at the moment. There will be more as يعني within the next maybe 10 days or something. There will be more. All right. All right. Okay. So let's start today. We have enough people. We wash our eyes with looking at a normal glomerulus. هذه الجلوميرولس اللي احنا نشوفها كل أسبوع. This is, as you know by now, PAS sustain. We are seeing the normal glomerular basement membrane. It is not thickened. Endothelial cells are flat. Podocytes, they are not activated. Mesangium is just normal. There is no expansion of the mesangium. There is no hypercellularity within the mesangial cells. The capillary loops, they are patent. ما عندنا endocapillary hypercellularity. We don't have break in the glomerular basement membrane. ما عندنا crescent formation. We don't have any hypercellularity within the parietal epithelial cells, and يعني from here we can't really talk a lot about tubules, but they seem إن إحنا عندنا brush border. They seem to be fine. عندنا brush border هني, and everything is absolutely beautiful. This is our weekly revision of what a normal electron microscopy looks like. The podocytes, they are regular, well-spaced, not very activated. شوية بعضهم they are activated, which is absolutely normal. There is kind of like, not really microvillus formation, but kind of like just a bit of activation, but there is no effacement of the podocyte. Fenestrations بيناتهم are maintained. Endothelial cells, they are flattened. The glomerular basement membrane is of normal thickness. Mesangium is not expanded. ما في sclerosis. وهذه عندنا one mesangial cell with the or maybe 1 or 2 within this glomerular tuft. All right. فنبتدي with our first case. خلينا نشوف what is there على قناة دكتور أحمد. Yes. All right. So case 1 is basically of a 58-year-old man with a history of untreated hepatitis C. He presents with a deterioration of the renal function and proteinuria. فجأة كان البيسلاين ماله at a certain level, and then all of a sudden he's يعني worsened in a very, very acutely. This is the HNE, and what is this pattern, guys? شنو هذا الباترن؟ عندنا خلوني أساعدكم نقول إن عندنا lobular accentuation of the glomerular tufts زي الوردة زي البتل صايرة كأنها وردة. Yeah, exactly. Yeah, excellent. Yeah, precisely. This is membranous proliferative glomerulonephritis. This is MPGN. Yeah, very well done. Very well done. Okay. فنروح على other glomeruli نطالعهم ونشوف إن عندنا هذين البلوجز. We have these plugs. There are eosinophilic acellular plugs within the glomerular loops. And then we have hypercellularity. We have hypercellularity within the mesangium as well as within endocapillary proliferation, both of them. And لاحظوا إن عندنا plugs. And we have a little bit of يعني exudative infiltration. We have lots of bits of neutrophils هني موجودين. There's lots of there's a bit of infiltration by polymorphs, شوية monocytes. هني we have inflammatory cells شكلهم polymorphs موجودين. We can kind of like judge tubules that are not very affected. ما عندنا واجد ATI over here. They seem to be, there is no epithelial injury, there is no fibrosis. بيطلع أوضح ويا special stains, but over here we can judge that the tubulointerstitial compartment appears to be fine. So this is predominantly a glomerular disease. This is a glomerular disease. Now this is PAS, and it highlights for us that there is definitely a hypercellularity within the mesangium as well as endocapillary proliferation. And then we have these eosinophilic deposits and plugs that are even more eosinophilic على PAS. You can see them over here, all these plugs. And this is trichrome, and يعني special stains, they will highlight for us very clearly the lobular accentuation of the glomerular tufts. It will be very, very obvious. Hypercellularity, if you compare, we are building a picture, right? So we are building a picture as we go, and we can definitely put our hands on our heart and say definitely عندنا endocapillary proliferation هني. Right. Silver stain is helpful over here because we can identify inflammatory cells in the loops. We can identify mesangium, hypercellularity in the mesangium, the endothelial proliferation. We can appreciate all of that. طبعا, in this particular disease, we might, يعني it's multivariable. We can have crescent formation, we can have even vasculitis. So it's every silver stain is helpful and kind of like it clarifies the picture for us even more. This is IgG and on immunofluorescence. And I would say this was an intensity of 2. Now, as you guys know, لما احنا we talk about immunofluorescence, we talk about where is the staining, the pattern, the intensity of the staining, the pattern of the staining, and the location of the staining. فهني this is kind of like granular. أكو نقطة 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 نقطة. Okay, dot 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 dot. This is granular. They're granules, right? And it is within the capillary loops. وشكله هني عندنا subendothelial because this is our capillary loop over here. This is the lumen, and this is just over the subendothelial layer. Over here, it is membranous. It is يعني مو إن هذا membranous disease بس قصدي إنه it is within the capillary walls. يعني صاير الباترن ماله كأنه على it's membranous. But this is not pure membranous because we have subendothelial over here, عندنا mesangial deposit over here. So this is kind of like a mixed picture. It's an intensity of kind of like 2 and or 1 to 2, and then we have on IgG, and then we have membranous, capillary loops, subendothelial, and mesangial. This is IgM. والاي جي ام احنا لو لاحظون احنا ما نتكلم عن الاي جي ام واجد في الاي اف because IgM either it is like part of the full house my lupus nephritis. Sometimes it will come out in يعني إذا كان عندنا يسمونه trapping. لما عندنا sclerosed glomeruli it might trap. It's just like IgM will trap in the sclerosed glomeruli إذا كان عندنا مثلا FSGS. But if it is dominant, يعني in this case, the IgM is dominant. It's stronger than the IgG, and the IgM here is kind of like 3 to 4. It's a very dominant intensity, and then we have it in the mesangium over here. Is over here in the mesangium. We have it in the subendothelial, and we have it along the capillary loops as well. So when you have an IgM dominance وشوية IgG or maybe a little bit of a brighter kappa than lambda, يعني more monoclonal. It's not like one of them is completely shut down with thani is kind of like present. لا, and one of them is more dominant than the others. You have to think about this disease. This is CD68, and CD68 really helps in kind of like confirming this diagnosis. And يطلع لنا كل الماكروفاجز اللي هي basically موجودة in the glomerulus, trapped in the glomerulus in this disease. So CD68 is very helpful in confirming the diagnosis in this case. And we will talk about the differential diagnosis. This is electron microscopy and of this case, and basically, okay, I'm gonna say to mute you all. Okay, I'm gonna mute you all. And then basically اللي عندنا هني إنه you can see this هذين glomerular loops, the glomerular tufts, and we see these electron dense deposits موجودين أكوهم. All right. الموقع مالهم خلينا نشوف الشطار. Let's see what you guys are saying. Okay. All right. Yes. Absolutely. Yeah. Well done. Well done. Yeah. So what we have here is subendothelial deposits, exactly. All right, so we have lots and lots and lots of subendothelial deposits. Where are we? احنا الحين على 5K. خلينا نروح على 10K. نروح على 10K ونتأكد إنه yes, basically we do have subendothelial deposits. Now, if you can identify إن عندنا نوع السبليتنج هني. There is kind of like a lucency, subendothelial lucency within the glomerular basement membrane. And we will talk about this more in our next case. But what happens is in the endothelial cells, they get injured with subendothelial deposits, and there'll be a damage to the glomerular basement membrane, and we will have this subendothelial lucency. ولما يصير عندكم هذا later on in membranoproliferative glomerulonephritis اللي هو على silver stain, as you guys know, الترام tracks اللي هو الدبل كونتور, basically because هذا اللوسنسي بداية الانجري. بعدين glomerular basement membrane, it will try to kind of like heal itself, and it will rebuild another lamina densa. فبيكون عندنا double lamina densa, and that is why we have this tram track appearance, duplication or double contouring of the glomerular basement membrane, basically because of the of this injury that happened to the glomerular basement membrane. All right, we are now على 10K, نروح أزيد, نروح على 30K, and we see and there is a substructure to these deposits. Okay, there is a substructure وكأنه بيدي, كأنه بيدي, يعني كأنه صاير كأنه beads. It's a bit cylindrical. خلينا نروح على higher power. And then there is, okay, so basically they are like beads, they are cylindrical, and they have spikes. Okay, actually بعضهم ممكن يكون عندهم spikes. So الشطار اللي قالوا إن this is cryo, it's exactly what it is. So this is a cryoglobulinemic glomerulonephritis. And on light microscopy, we have a strong PAS positive intraluminal deposits, and they are known as cryo plugs. And they are very eosinophilic, very bright على PAS. MPGN is the most common pattern, ممكن يكون crescentic. It can have vasculitis as well. It's basically in this case we have hepatitis C, and I will talk to you very briefly about the 3 types of cryoglobulinemia. We have hepatitis C, we can, يعني, we are more likely to have type 2 rather than type 1 or type 3. We can have either type 2 or type 3, but it's more common type 2. And in this case, it is IgM dominant or mixed IgG ويا kappa dominant staining. وزي ما قلنا kappa dominant يعني مو معناته restricted, يعني it's not monoclonal, بس الكابا is brighter than the lambda. ويكون عندنا ديلين الميكروtubular substructure ويا الهولو centers, شوية عندهم spikes on the surface, and they're quite big. They range from 25 nanos to 35 nanos in diameter by electron microscopy. So احنا نتحكي about the sizes of the substructures. عشان تذكرون المحاضرة مالت الأسبوع اللي فات, definitely bigger than the amyloid اللي قلنا إن it's يعني kind of like 7 to 16 or kind of like, and then it's around يعني the same range of size of immunotactoid. Now quickly let's talk about cryos. Cryos, basically they are proteins that precipitate or they clump at cold temperatures. لما temperature تكون أقل من 37. And they can plug the blood vessels and cause vasculitis, different parts of the body, يعني مو بس الكدني. The causes of cryoglobulinemia يعتمد على حسب التايب. Type 1 is mostly has to do with hematological disorders, multiple myeloma, Waldenstrom, and they tend to be monoclonal. Type 2, it is يعني mostly due to infectious causes, and it is related حق hepatitis C, hepatitis B, even hepatitis A, and basically hepatitis, it is a late complication حق hepatitis C. Type 3, we can see it via autoimmune diseases, via lupus nephritis, أعتقد ويا Sjogren's بعد. I'm just يعني talking off the top of my head. So basically these are the different types. طبعا the diagnosis of cryo is يعني made يعني predominantly based on, and this is what the experts say, based on يعني identifying the substructures في electron microscopy. If you didn't do the electron microscopy, it is better to say that this is a glomerulonephritis with features that are suggestive of or highly suspicious of cryoglobulinemia glomerulonephritis. CD68 طبعا زي ما قلنا في الاميونوهيستوكيمستري إذا سويناه is very supportive. Okay, right. Quickly we touch upon MPGN pattern. What should come to our mind when we see an MPGN pattern? Dense deposit disease, C3 glomerulopathy. We'll be talking about these and clarify them in one of the cases. طبعا cryo. Lupus nephritis in terms of diffuse proliferative اللي هو الكلاس 4. إذا كان عندنا post infectious glomerulonephritis in the subacute اللي هو non exudative. حتى ال IgA nephropathy إذا كان مثلا يعني very advanced ويا mesangial hypercellularity as well as endocapillary hypercellularity that's involving a lot of the glomeruli. Now, all of these, we will be able to make this distinction based on الIF, صح؟ يعني lupus nephritis بيكون full house. البوست infectious بيكون البيشنت عنده في السيرم low complements as well as a dominant C3. IgA nephropathy بيكون عنده dominant IgA أو only IgA with lambda. lambda dominance. الchronic thrombotic microangiopathy ليش خليناها هني؟ Because we are TMA you can have يعني في late TMA مثلا a TMA that has happened and passed it would have injured the glomeruli وبيكون عندنا الدبل كونتور and الترام تراك في الجلوميرولار basement membrane and طبعا الIF بيكون completely negative unless the patient has other diseases. But if this was just your على قولتهم typical TMA بيكون الIF completely negative. All right, let's touch base. So just give me a sign and you guys are fine. Everything واضح. Okay. You missed the tram track on silver. ما أعتقد إن إحنا كان عندنا tram track in this case. I didn't. Not on this case. Yeah. All right. So very nice. All right. The second case. This is actually a very interesting case. That I'm presenting to you to يعني أقول لكم هاي concept. All of these cases are actually cases that I have worked on and did. They're very unique part of the cases that we have seen at UNC. So this case is quite unusual. لأن we actually had يعني we had to do lots of levels in ما شفنا lesion and we suspected لما شفنا electron microscopy we kind of like oh wow, and then we went and read the literature and we found yeah, there is something in the history that's related to this patient's presentation. Anyway, شكلي قاعدة أحرق الفيلم. Okay, a young lady with Crohn's disease. She's on NTTNF medication, تاخذ Humira. And as you know, Humira is one of the anti-TNF, the immunomodulators. It's being used to treat lots of autoimmune diseases. Crohn's أعتقد بعد psoriasis and يعني kind of like a group of autoimmune diseases. She presented with acute renal failure. وهذا basically look على ال HNE and يعني the first thing that really strikes you is kind of like التوبيوز شكلهم مضروبين يعني sloughed epithelial cells, and there is very bad يعني ATI, acute tubular injury, and look over here وهني ال blood vessels شكلهم a bit swollen. There's something going on, and the glomeruli شكلهم bloodless. You don't see, and the loops are not يعني patent at all, right? They are not patent at all. نشوف الشعب شو يقولون. Okay. So let's go on higher power. عندنا هذه الجلوميرولس, all right? And then we have نوع يعني basically kind of a watery kind of like appearance within the mesangium over here. And then we have all these red blood cells قاعدين إلينا داخل الميزانجيم where they don't belong. And the glomerular loops, lumina, they are not patent at all. And all of these red blood cells, right? Okay, and this is when we talk about mesangiolisis, guys, this is what we're talking about. In the mesangium, it looks like it's breaking down. This is mesangiolisis. The mesangium is breaking down, and we have these red blood cells within the mesangium. The other thing, تعتقدون what do you think is يعني filling الlumen يعني what is there is okay خلينا نجي هنا عندنا lobular accentuation صح. This looks like an MPGN pattern, right? This looks like an MPGN pattern. لكن احنا ما عندنا mesangial hypercellularity, عندنا mesangiolisis. And illumina, they are occluded, okay? But what are they occluded by? They're not occluded by inflammatory cells. It's not exudative. They are not neutrophils. Okay, هذا الtrichrome. What do you see over here? Lots of red blood cells, which appears to be fragmented and broken within the mesangium. And also completely occluded glomerular lumina. And what we have هني بعد there's a blood vessel شكله بعد عنده broken red blood cells. There's something, there's a يعني kind of like abnormality in the wall. And yeah, species هني, there's something here لا. Okay, this is our silver stain. Let's go. What do you think is occluding the lumen? What is occluding a capillary lumen? This is your whatchamacallit, your silver stain. And then we have a little bit of أكو هني لا we have a little bit of tran track هني أكو. There is focally here. We have أكو هني over here. We have duplication, double contouring or duplication of the glomerular basement membrane. Let me see what you guys are saying. Yeah, we have schistocytes, endothelial swelling, TMA. Very well done. Exactly. This is endotheliosis, all right? This is endotheliosis, and this is thrombotic microangiopathy that is caused by endothelial injury, endothelial swelling that basically completely occluded the lumen of the glomerular capillary, glomerular tuft, and it basically يعني صار عندنا schistocytes وانضربوا ال red blood cells, and this is most likely related to the drug. صح؟ الدرج اللي تاخذه المريضة. الدرج سبب endothelial swelling, the endotheliosis, and caused thrombotic microangiopathy in this patient. Okay, so this is an electron microscopy, and as you can see, these are the endothelial cells, and they're completely swollen, and there is this ischemia and injury to the glomerular basement membrane. عندنا basically lots of kind of like holes within the glomerular basement membrane, and over here حتى الميزانجيوم is kind of like breaking down, and we have mesangiolisis. البودوسايتس يعني they're flat, they're sitting down. Again هذه كلها الاندوثيليال سيل. ذكرون الاندوثيليال سيل اللي نسلم عليها بداية كل سيشن how flat she is. أكيها شوفوا هذه البريئة. Look how flat she is over here, right? And then شوفوها لما تزعل. She got irritated and upset and injured. What she looks like, right? So so this is endotheliosis, this is endothelial swelling, and then this is what we're talking about what happens kind of like subendothelial lucency in the glomerular basement membrane. هذه بداية الانjury over here, and then as it heals over time we will have a new lamina densa over here. طبعا ما بتكون زي الأول، ما بتكون normal lamina densa, and that's how we will have double contouring. Now these are just complements that are being trapped يعني. And why are we ignoring them? لأن إحنا ما شفناهم على ال IF, and also we, you know, there aren't a lot of them موجودين في ال EM either, so we're not going to pay a lot of attention for these. All right, so this is a TMA that is drug induced. الجلوميرuli بيراونا endothelial swelling. Sometimes there will be fibrin thrombi. بيكون عندنا ischemic collapse of the capillary tuft. It will look bloodless. بيكون عندنا mesangiolisis بسبة ischemia. We can have a duplicated glomerular basement membrane in the chronic phase, and like we said, it's because of the الانجري and subendothelial endothelial injury بيسوي لنا subendothelial injury، بصير عندنا lucency، بصير عندنا deposition of a new lamina densa. بسبة الاسكيميا tubular interstitial compartment بصير عنده ATI ويا degenerating epithelium. ممكن يكون عندنا interstitial fibrosis و tubular atrophy إذا كان عندنا underlying chronic kidney disease, or this is kind of like a chronic phase. And the arterioles can show endothelial swelling بس ما بيكون عندنا inflammation. So it's not vasculitis, but we can have endothelial swelling. Generally, خلينا نراجع ال TMA. In this case, this was TMA that was drug-induced, but generally, TMA can be due to sugar-like and sugar toxins. ممكن يكون genetic defects that have to do with complement activation and regulation. ممكن يكون سبب non-enteric infections اللي هو pneumonias, can be due to a different variety of drugs. Malignant hypertension, طبعا one of the common causes for TMA. Enteropathy transplantation due to bone marrow transplant, or as part of acute antibody-mediated rejection of the kidney. Radiation can cause it. Systemic sclerosis, and I think في السيريز مالت lecture series مالتنا لما احنا كنا talking about, I showed you a case of systemic sclerosis that was that led to thrombotic microangiopathy. Autoimmune as part of antiphospholipid antibodies, ممكن حتى pregnancy associated and postpartum, sometimes malignancy can cause TMA. Yeah, the cells in the lumina, they were endothelial cells. Mesangiolisis, how it appears في ال HNE, let's go back. It's just watery, really, يعني. It's kind of like يعني when you see lots of renal biopsies, you'll be able to appreciate it. But basically, it's like you can see that there is something breaking down over here. Can I zoom in? I don't know. You can see in the أشياء kind of like watery over here. So things are breaking down. Okay, I'm breaking down. Things are breaking down over here. أكو هني. It's slices. It's a breaking down. It's not your normal mesangium. How it looks on electron microscopy, أكو هذا الميزانجيال cell, and you can see there's lots of lucency around the mesangial cell. It's kind of like there is something breaking down. It's kind of like disintegrating. It's disintegrating. Okay. All right. Case number 3 ما عندنا history. وش معناته؟ سهلة. Yeah, paler in color. Yeah, thank you. Yes. All right. So, case number 3. What do you guys see? All right, very interesting answers. Very, very interesting answers. Right, cool. So, عندنا mesangial expansion, صح? Right, we have mesangial expansion. And there is definitely thickening in the glomerular basement membrane. There is thickening, صح? So we don't know whether these are deposits or not, right? We will need to know what's there in the IF. Oh, I agree. There is an area of focal segmental sclerosis. A segment of the glom is attached to the Bowman's capsule. And there is mesangial expansion. في عندنا mesangial expansion. ما عندنا endocapillary proliferation. لا يوجد. All right. So we have mesangial expansion. Might be deposits, maybe not. We'll have to see IF. And عندنا focal segmental glomerular sclerosis. And there is thickening of the glomerular basement membrane. And again, mesangial expansion, vague nodularity, maybe not completely KW nodules, but vague nodularity. Something else is helping us in making the diagnosis. طالعوا arteriole over here. There is thickening of the in the arteriole wall. كنا في شيء over here. لا, there is kind of like patchy coloration within it. This is HNE, but there is patchy coloration within it. But it is definitely thickened, right? So as you guys know, when we see this, we think, are we dealing with diabetes? Are we dealing with fibrillary? Are we dealing with amyloidosis? And let me tell you that in this case, an IF can completely negative. And this is a globally sclerosed glomerulus, and عندنا هني hyalinosis within the arteriole. And we have KW nodule هني مستوية. And you remember when we talked about formation of microaneurysms لما الميزانجيوم pulls away the glomerular basement membrane, and it forms for us a focal weak point within the capillary wall. ويصير عندنا microaneurysm. And this what confirms to us in we are not dealing with deposition of, لأن زي ما قلنا يمكن ال IF ما في glomeruli. Silver is positive. And then this is a sclerosis and it's laminated. طبقات 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 طبقات. So this is definitely not amyloidosis, not fibrillary, and not monoclonal disease. This is a sclerosis because silver is completely negative and we have this microaneurysm formation. So what did you guys say? Cool. Okay. اللي قالت somebody said hypertension nephropathy. Hypertensive nephropathy, we will have I'll get back to you regarding this. الهايبرتنسيف نفروباثي ممكن يكون عندنا فوكال سيجمنتال glomerular sclerosis، بيكون عندنا hyalinosis، بس ما بيكون عندنا الميزانجيال expansion. We will not have the vague nodularity. We will not have the KW nodules with hypertensive nephropathy. Now, with السؤال اللي انطرح بالنسبة حق الاميونو fluorescence, what we will have with diabetes is called glomerular basement membrane and tubular basement membrane accentuation on IgG. And the reason إن إحنا نسوي albumin, and the center where I worked in, they were not doing albumin in that because the reason إن هم كانوا يسوون الالبومين عشان يتأكدون إن they are not missing an anti-GBM. يعني you are not missing an anti-GBM. ولكن اللي يصير في glomerular diabetes on IgG إنه فقط يحددها, but it is not bright. يعني it's not very intense. anti-GBM يكون bright green, intensity of 4. And we will have IgG as well as having C3 بعد بيكون موجود. ولكن what we will have on diabetes is basically an accentuation. يعني كأنه واحد أخذ قلم وحدد glomerular basement membrane. This is because it is thickened. ولكن it will not be bright. It won't be bright. And honestly, guys, you will have to see it in real life cases to appreciate it. And even for me, when I was in training, it took me a long time, and I was always worried that I will miss an NT-GBM. But trust me, NT-GBM, it will be extremely bright على ال IgG, and that is why أنا قلت لكم على I didn't mention it يعني unless until the question was asked, لأن I didn't want to confuse you. It's basically called IgG accentuation on the glomerular basement membrane as well as the tubular basement membrane, but it is not positivity. The intensity مي موجودة. It's only kind of like accentuated. Yeah. Okay. Right. So diabetic nephropathy بتكون changes موجودة with type 1 or type 2. They show similar pathological alterations. early changes زي ما قلنا من قبل when we're talking about في المحاضرات إن thickening of the glomerular and basement membrane. بيكون عندنا glomerular hypertrophy. بيكون عندنا later on diffuse mesangial sclerosis. sorry, واحدة من early changes اللي بتصير بعد ويا thickening of the glomerular basement membrane إنه ممكن يكون عندنا mesangial hypercellularity. After that, we will have diffuse mesangial sclerosis. That can result in kind of like vague nodularity, وبعدين لما تنضج تصير nodular mesangial sclerosis. وthese acellular nodules بيكون اسمهم Kinsey Wilson أو KW nodules, and they will have a laminated appearance اللي هي كذي طبقات over time sclerosis اللي نشوفها على جونز silver stain. الهايلينوسز either إنه يكون عندنا fibrin caps اللي هو الهايلين accumulation within the glomerular capillaries, يعني بصير كذي كأنها glomerular capillary عليها cap, أو إنه بيكون عندنا capsular drop, which is basically a drop اللي هي جاية من Bowman's capsule والparietal epithelial cells كأنها بتطيح على الجلوميرولس. يعني this is a drop, a capsular drop, okay? And in diabetes, how do you differentiate between في الهايلينوسيس between diabetes and hypertension? في diabetes, both of the efferent والefferent arterioles اللي داخلين الجلوميرولاي, both of them بيكون عندهم هايلينوسيس. بينما في hypertensive nephropathy, it's only the efferent. It's not the efferent لأنه systemic, لا لأنه جاي من systemic شو اسمه vasculature. في advanced cases of diabetic nephropathy ممكن يكون عندنا FSGS, because as you guys know, FSGS can either be primary or secondary. One of the secondary causes for FSGS is diabetes, is hypertension. وبيكون عندنا بعد substantial interstitial fibrosis و tubular atrophy الإفتة. I just want to make sure إن موضوع immunofluorescence واضح. Did you guys get what I was saying about the immunofluorescence? About it being basically accentuating, it's highlighting the glomerular basement membrane and the tubular basement membrane rather than it being truly positive. Yeah, okay, brilliant. Okay, and اليوم احنا خلصنا من وقت. لأن I was wondering إذا كان بيصير في خربطة ويا الكرايو, بس يعني الحمد لله we didn't. It was smooth sailing. تسلمون, شكرا. Thanks a lot. Thank you guys. Thank you for attending, and thank you for your enthusiasm و حضوركم وشطارتكم and all of that. I'm very, very pleased. I'm very, very pleased. Thank you so much. Thank you. Thank you. Somebody was trying to ask a question here. What is the difference between what? Somebody was trying to ask a question. Dr. Nasira, do you want to pose ischemic glomeruli and what? You wanted to inquire about ischemic glomeruli and PAC. What do you mean by PAC? الIF. Okay, inshallah, I will. I'm not following. Sorry, Dr. Nasira. I'm not. Pain shit. I'm a bit confused. I don't get your question. You can send it to me over Messenger. Glomerular. Okay, complete glomerular sclerosis. Okay, I get it. اللي هو global glomerular sclerosis. Okay, so الاسكيميك glomeruli ان هم they look bloodless يعني هم they are not sclerosed. They are not sclerosed. You can still see the glomerular tufts, the outlines, you can see the mesangial cells, ولكن they're not sclerosed. They just look bloodless. Global glomerular sclerosis is basically ان احنا there are no patent glomeruli. يعني let's see وين هذا. Okay, yeah, فقدت there is no patency. لا يوجد patency, and it's يعني completely replaced by sclerosis. إذا كانت مثلا part of the glomerulus, it will be segmental glomerular sclerosis. If it was all of the glomerulus, it will be global. بينما الاسكيميك هناك is there basically there is يعني no blood going through them. They're completely bloodless. في question جاء إلينا regarding IF again for diabetes. لما احنا نتكلم عن when we are talking about IF, we're talking about intensity, and when we talk about intensity احنا قاعدين نتكلم عن يعني brightness. يعني look, this is so green, right? this green هاللون, this if this was linear on IgG, if this was IgG and it was completely linear, it was very bright, intensity of 4, وكان وياها بعد C3, then we are worried and we are dealing with anti-GBM, which is a very serious disease. It's kind of like a medical emergency. وياها crescents, and the patient can lose his kidney completely and probably lose his life. لكن شنو يصير على الدايابيتيز؟ Unfortunately, I don't have a picture. اللي يصير على diabetes إن it's not bright. It's just highlighted. يعني شوفوا هني مثلا you can see شوية أغمق من كذي. It's lining the tubular basement membrane. It's lining يعني يمكن هذا اللون هني. It's lining capillary loops, but it is not bright. It is not intense. Not very. It's not يعني it's not green. No, it's green, but it's not مو مولع يعني مو كأنه لمبة يعني it's not like a light هاللون. It's just إن أحد ماخذ قلم أخضر وماشي على ماشي على شو اسمه glomerular loops, right? I'll see if I can show you a picture, بس يعني we didn't really take pictures of it, but just take it from me إن يعني if it wouldn't be an intensity of 4, it will just be يعني كأنه very faint line along linear, it's not granular, it's linear, highlighting the glomerular basement membrane and the tubules. Okay. Capsular drop, sure, I can show you the capsular. Can we see example of double contour? I can do that. شنو the causes of mild mesangial expansion than hypertension or IgA? Okay. في ال IgA basically نحن عندنا mesangial hypercellularity. Hypertension is part of the sclerosis that happens. بس mesangial expansion is more in diabetes. And how do we differentiate between, يعني قلنا إن diabetes early on we can have mesangial hypercellularity. How can we differentiate between diabetes versus IgA? إن هناك بيكون في عندنا IgA positivity, لا صح? We have deposit. We will have the immunofluorescence positive for IgA. IgA, but it will not be in diabetes. Hypertension will be completely negative unless عندنا areas of sclerosis وزي ما قلت لكم we will have entrapment of C1q, of IgM, of C1q, IgM, and C3. It traps. Bottom line, diabetic nephropathy with FSGS. Was FSGS part of the parcel? لا احنا كنا we're talking about part of complications اللي ممكن تصير. But over here, yeah, اكو هني عندنا we have FSGS. FSGS can happen as a complication of, if you think about it, إن احنا صار عندنا injury to the glomerular tuft, صار adhesion to the glomerular tuft حق بصير عندش يعني segmental sclerosis. So FSGS can happen in diabetes mellitus, بيكون secondary to diabetes, secondary, or it can even happen to with hypertension. ساعات يكون عندنا segmental sclerosis ويا IgA ويا healing crescents, and it's an injury that has happened. So FSGS can either be primary due to podocytopathy or secondary due to يعني a variety of diseases, and on the top of the list would be diabetes and hypertension. All right, guys. Okay, brilliant. Okay, thank you so much. Shukran, everybody. Good night. Have a nice weekend, and see you next week. Bye-bye.